Bridging the gap between nursing leadership and your clinical supply chain is our episode topic. My guest is Marianne Bondanza, a registered nurse and associate director with BRG's clinical supply chain. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Marianne, thank you so much for joining me today.
Oh, thank you for having me, Nick. This is a pleasure.
So tell me a little bit about your story from practicing in nursing and how you got into the clinical supply chain work that you do.
I knew when I was a kid, I wanted to get into nursing. My grandmother was blind. I lived with her and my parents in a little house in New York City, and I was in charge of taking care of her since I was 5. And from there, I always looked at healthcare in a different format. And my uncle was a physician up the street from us, so he would come and take care of us at the house. I became a candy striper at age 15 at a small community hospital out in the eastern end of Long Island, and went to go to nursing school out of the eastern end of Long Island. I got very involved with clinical research when I was at Georgetown down in the DC area, and have never stopped since then.
What did you do research on at Georgetown?
I did clinical trials. And many years ago, when I first joined Georgetown, I was on the Georgetown clinical team. We were doing, I'm really going to date myself here. We were doing intrathecal treatment of cancer patients. Can you inject into that? And so that's pretty much become mainstream since that point in time, so that these things really work. And I've done numerous types of studies from intrathecal through cardiovascular to Parkinson's patients. I was involved with management, moved around the country for different positions in neuro, mostly in neuro and oncology at that time. And I don't know about you, but as nurses, we tend to be looking for that place that we belong. And so I kind of hopped around from intensive units to different floors and ended up in the operating room where I found home. I love the OR. I was a clinical manager for many years back up in the eastern end of New York and just loved it. One day, my office was being renovated from where the supply area was, and they were creating new office spaces for everyone. And one of the contractors came and found me along with my director, and we went into this room that they were renovating, and he pointed to the ceiling. And we both looked up there, and there were boxes and boxes, probably close to 100 boxes of endomechanical stapling devices, which we use in laparoscopic cases in the operating room. I had no idea how they got up there. Why were they up there? I was horrified to hear that we were now reordering products because we thought we used them. So it was an eye-opening experience for me. I realized at that point that nurses need to spend more time looking at clinical supplies, inventory management, and how we treat our vendors. We need a partnership between both the manufacturers, the vendors, and our supply inventory management. And so it was just a rude awakening. We ended up putting some new policies in place as far as vendor policies, as who can come and go as they need to, participations. We had major overhaul on inventory management at that point to keep an eye on exactly how many products do we use and how many products are coming and going in this building. Nobody was watching what was happening with these products. So that's how I got involved. I got recruited at that point to supply chain. I was in the process of moving from the eastern end of Long Island, where I was, down to Florida, and we got recruited into supply chain management. They pulled a lot of us nurses out of the ORs and put us into what was called at the time a clinical resource directorship. And what we were in charge of, it was the early stages of clinical value analysis, was looking at supply costs, looking at management, and maintaining our vendor relationships, yet putting restraints on who comes and goes in a building, which really has transformed into many different aspects since that time. We have now what's called rep tracks, or different simpler, different programs that vendors have to go register now and put in all of their credentials. Why are they at the building? Do they have a meeting with someone? Who is that meeting with? So there's quite a criteria now for this relationship between hospital organizations, healthcare entities, and it could be a multi-facility system that's nationwide. Yet the vendors have to apply for this. And if they refuse or they do not want to be participating in part of this, they're no longer allowed to come into the building and we can't buy their supplies.
So things have clearly evolved over the last several years using rep tracks and things of that nature. Are hospitals and healthcare delivery organizations, do they typically have clinicians that work in your type of work now, dealing with product decisions, supply chain, et cetera?
That's a really good question. I would say from my experience going around the country and having many different clients, I would say only 50% of my clients in healthcare organizations have a clinical person on their supply team. Some of it is driven by what's called value analysis, which those clinicians are looking at clinical supplies, the cost of these clinical supplies, who is requesting these devices to come into the building. They need to go through reimbursement. Is this product a reimbursable product? Is it just a product that's here today, gone tomorrow kind of thing? And we always want to look at value-based purchasing. And that is how the CMS is looking at and rewarding hospital systems to receive reimbursements. You answer your question, no, I don't see more than 50% of clinicians that are involved in supply chain at this point.
What are some of the priority concerns that exist right now in clinical supply chain?
I know that everybody has become acutely aware of supply chain in general, that term, from the pandemic. We started to hear about supply chain back orders and boats floating around, barges floating around out in the ocean somewhere. On some of those barges are also clinical supplies for healthcare organizations. Since the pandemic, we have looked at many different back orders on clinical supplies that have a critical deviation in how we treat our patients. Some examples of supply chain that we have seen, the back orders have been on stents, cardiac stents. They've been on telemonitoring systems such as transducers. A simple device, which sounds very simple, is the vacutainers in the lab drawing blood. There was a shortage of plastic and no one could get vacutainers. So I know that sounds very simplistic, but you think about the overall effect that has on nursing and drawing blood on a patient. We couldn't get vacutainers. So yes, there are other ways to draw blood, but as nurses these days really drawing blood with a needle anymore and a syringe, or even with butterflies, they had to be retrained. We had to make sure that there were safety issues that were addressed, such as needle stick injuries. You have nurses drawing blood with a syringe. Now you've got to transport that blood back into a blood vial. How are they doing that? They're literally putting the needle into the vial, which terrorizes me. I don't want to see anyone get hurt. So many of the supplies are simple, but yet they have a critical point within supply chain and helping our staff and our nursing to stay safe and for the physicians to have the products that they need to have for our patient care.
Okay, so you've talked about kind of two things that are going on here when we have supply chain shortages. One is looking at what do we do in the meantime? What are the alternative products that can be used, or how do we accelerate getting that product back in here? And then the second is, along with the what do we do in the meantime, if it's a different type of product, is there education around that, or is there a different type of procedure? Are you doing both of that type of work, or where does your responsibilities lie?
Our responsibilities lie in doing both, basically. Just as an example, just the other day, I was on a call with a vascular graft corporation, a large company, and my client to discuss new contracts, working with them to assure that the products the physicians will have. And in the interim of meeting with the regional VP of this company, he mentioned that one of their main products that this facility uses and their vascular surgeons uses, they're running low on supplies because many of the products or the raw data and supplies, materials come from overseas. They actually manufacture it here, but they can't get the product. So for us, when I heard that, immediately the red lights went on. I said, we need to make sure that the client is aware of this and have a possible plan B backup. We can't wait until the manufacturer runs out of supplies. So what I'll work with is, this coming out of the cath lab, is work with this particular cath lab director, let her know what's coming up. That could be a possible issue for them, a critical issue, because these surgeons are looking for this product and it might not be available in the next few months. Can we look at a clinically accepted product that would help them and help the physicians go forward with not having any issues in between, without having any supply issues in between? So the next step, we'll work with them and find out what other products might be a substitute that we could now have education involved with, clinical education at the hospital level to help with some of these transitions if need be. But being ahead of it is so much easier than being behind it and scrambling for the product or substitute products that they would need to have.
You talked earlier about 50% of the places that you've been have nurses in these types of roles as employees within the organization, whereas
Mhm.
about half don't. Are there any commonalities of what you've seen in terms of how things operate in the organizations that do have nurses in those roles versus the organizations that don't?
What we see is when clinicians are involved in clinical supplies, in supply chain, it allows the clinicians to have a voice, which is sometimes they do not have a voice when there's not a clinician. Many times what we find is that supply chain is looking at their group purchasing organization or their GPO, who has the best contracts? How are they going to reduce costs? Which, of course, is naturally a process that we want them to continue to do. But by doing that, they end up changing products without really understanding the clinical implications that could have on patient outcomes for the physicians and for the staff. And just as an example, when I was working in the operating room, that's my background, is I came from the OR. I remember putting on a pair of sterile gloves and my fingers went right through the tips. And so did the surgeons. They just ripped, the gloves just ripped. And our bottom line was low bid. So it was just a low bid that they took advantage of, that they were going to save so much money. But meanwhile, it was a disaster. And so at that point, we had to break scrub, get away from the field that we were about to do surgery and start all over again. And those kind of issues, in my personal experience, really hold true for me. And I like to see that supply chain and nursing leadership have an interdepartmental, interdisciplinary meetings, and that they're a partnership, that they need to collaborate on efforts. That what supplies are they bringing in? Is this something that's going to only be utilized in one department, such as labor and delivery? Or is it in the emergency room, labor delivery, not the intensive care units? We don't really know until we actually look at the data and the impact of where all these products are going and who is going to be affected. And we like to bring all of those people to a round table to be able to discuss they get their opinions and we have the vendors bring in some supplies or a product, some samples, so that everyone can try these products. We can run it through a revenue cycle to make sure that the products are reimbursable products. And usually I'm asking my physicians, because normally the new product request comes from a physician or a surgeon. I'm always asking them, what are you going to give me in return? I'll give you this new product if you get rid of the old one. You can't have both. You can't. We can't just keep stocking the shelves with all of these products without taking something away.
How do you measure value in supply chain?
We base our value on current pricing and look what we have seen in their data that they have submitted to us. And we benchmark that based on what we see in the current market. And then we can actually, once we have renegotiated new contracts and new price points, we can go back and re-benchmark that and actually show the complete savings based on value for the institution.
Talk to me about working with frontline staff. How should frontline staff be involved in product decisions?
When we look at product supplies and clinical supplies, many times, as I mentioned earlier, supply chain is making these decisions. And what we find is the frontline person that's using these products, for the most part, are clinicians. And they could be nursing and it could be respiratory therapy. They're all utilizing these products, yet they have not been part of bringing the correct product in for the products that they need and the services that they provide. For example, tube feeding seemed like a simple product. Okay, we'll look at the one that has the best cost reduction. Does that tubing align with the boxes and the monitoring system and then the pumps that we use? Has anybody brought in the product so that the nursing staff can actually make sure that they work? It's just important for nursing staff to be involved with supply chain so that they are the final end users of the product. And I'd like to be able to say that always happens, but from what I see, nursing is left out of a lot of decisions that they should be more involved with.
If I'm a CNO right now in an organization, what three things should I maybe walk away with from this episode of things that I need to either one, do in my organization, or two, ensure that it's taking place to close that gap if one exists, or to solidify it and to solidify the closed gap with a healthy working relationship?
Great question. What I would say is I know that for CNOs that are listening and for the directors or VP levels, the most important piece here is to sometimes step away, to step back. I know that we get bombarded with nurses or directors and departmental differences and what they need, and everybody has needs. But I think for the CNO, they need to step back and be on the outside. They need to be looking in the window of their hospital and their system and look at what's really happening. Are these issues something that can be changed, or are they issues that need to be collaborated on with different departments and with supply chain? The other piece of this is inventory management. How are these products being brought in? Do they need to have every single widget that a physician calls for? I think at some point that they really need to be able to be more involved with some discussions upon what products really are necessary, what are value-based products that need to be brought in, and what are the clinical outcomes that we are looking for. The other piece is standard of care. The last piece, I think, which is critical. Standard of care means that there can't be deviation on every unit for different products and different supplies. I don't know, Nick, if you've run into a surgical supply room where you look on the wall and there's 3 different IV start kits, or there's 5 different pulmonary kits, or there's a wall of sutures. Like, wow, I don't know which one I need. And the nurse on the front line who's running into those supply rooms really needs to just go in and get what she needs or he needs and go back to the patient's bedside. They don't need to be sitting there trying to figure out which product they need. So standardization is something that I think is key for true standard of care, bringing value to the patients, bringing value to supply chain, and really utilizing their knowledge to be able to work side by side with supply chain to make these things happen.
I'm smiling a little bit because as you were mentioning that, I was thinking about some prominent IT leaders that wear the same thing every day. And when you ask them, why do you wear the same thing every day? What they've told news stories or I've heard on the news is it's one less thing that I have to worry about. And that's clothing. This is one less thing the nurses need to worry about. Different, the IV start kits mean different start kits means you have different processes that you need to do in terms of how you handle the needle hub and things of that nature. And think about the efficiencies on a labor side that you could also get out of just them not thinking about the differences in products.
Absolutely. We want our nurses and clinicians at the bedside, not standing in a room trying to decide which product they need. And then, the other piece of this, which we can touch upon, is that there are so many traveling clinicians right now, people coming in from all over. And many times they don't know how to use a product, which can really put the liability on the facility itself. So being able to be standardized when you're bringing new people in and they're going through a new hire process, even if they're only traveling, they can see what products are being used. And if they don't know what that product is, or they don't never seen that particular setup, they could ask questions and have somebody help them with that. Versus, okay, we have 3 of the same setups, but they're a little bit different. They each contain a different product or a different manufacturer. And this is how we do this one. Nobody has time for that. No one has time for that. And it bothers me. We all took a vow to do no harm to our patients. And we're also, and I take very seriously still to this day, is that I'm the patient's advocate. I'm here for patient safety. I want to make sure that the products that we're bringing in are products of quality that are going to improve patient outcomes, and that the physicians and the staff will be able to utilize within this whole system.
One of the other things that you talked about was the need for the nurse executive to get out of the way and be a supporter. And this is something that one of our earlier podcast guests also honed in on. Cheyenne Fisher, we had her on as a guest, I think back in late February is when the episode aired. And she talked about, I'm here as an executive sponsor, but at the end of the day, it's that frontline staff that needs to make those decisions so that I can support them. Can you talk a little bit more about that?
For the most part, it turns out there's little to no communication between department to department, from supply chain many times to what's being swapped out. So I think for Cheyenne, and what she reiterated was getting out of the way, is meeting with her directors, meeting with her clinical managers, and letting them know that she is going to be there as a support mechanism, but don't expect her to be at every meeting. She's got a busy world. That the directors and the managers of each department can manage this. We need to get clinical education involved whenever there's product switch or variations of products. And we need to make sure that leadership is there to help them and to guide them, but that there are the frontline nurses that need to be able to give input into what's going on. She had talked about inventory management and cleaning up supply routes. Definitely go in there to make sure that all of the IV solutions are together, or the certain products, respiratory tubing or trachs, they're all in the same place so that they're not scattered about a room. We need to be able to coordinate that with the frontline nurses on each one of those units to make sure that they're aware of what's going on. Frontline nurses need to be able to say, this product works or it doesn't work.
Marianne, thank you so much for taking the time today to discuss all things supply chain and the relationship that they need to have with nursing leadership. Really appreciate your time.
I appreciate you having me. Thank you so much.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.